Well, hi, everybody, and welcome. And thank you to Ethel for joining us today. I'm just going to pull up the schedule for the next few weeks because we do have a couple of things that are for people to just know about. So next week, which is March 24th, let's not rush, we have a talk from Dr. Connie Trimble about HPV vaccines. So looking forward to that one. Keep that in mind. And then the following week, Richard Moore and I are going to do some CROI updates from the recent meeting in Seattle. And the week after that, we have a case discussion slotted in. And not to give away too much, but I think we'll have some really interesting updates from Liz Gillam's case. Liz and Francesco Simonetti and I have been emailing about that case, and so some updates there. And then we have a few cases that have been sort of backed up. And then on April 14th, Monica Gandhi is coming from UCSF to sort of give her directly she's coming on Zoom to give her presentation of the experience with long-acting therapeutics on Ward 86, which I think has been much talked about from CROI. So we'll sort of gloss over that in the CROI review, but because we'll get it straight from Monica herself in April. And then Paul Sachs is coming in May, and Jean Keller is going to talk to us about GYN and women's health topics. So lots of really interesting stuff coming up. But without further ado, I'm going to get to today's. And one thing, Sheila is going to come on at the end of the call today with some Bartlett updates. So we're going to do about 45 minutes of Ethel and me giving an overview of new agents in the clinic. And then we'll hand it over to Sheila for some updates at the end. So I'm just going to switch this to slideshow. And does that have the right screen showing? Yep. Great. Thank you. So today we're super fortunate to have Dr. Ethel Weld here with us. She's often here with us and is often called upon just to extemporaneously comment, but actually this time a little bit more advanced notice. So as many people know, she's a MD and a PhD with a joint appointment in both clinical pharmacology and infectious disease, and has been involved in a lot of the registrational and exploratory trials of a lot of these newer agents. So we're super fortunate to have her here at Hopkins, and also has good relationships with a lot of the people who can help us with expanded access and things like that. So the goal of today's talk is to go some of these over what are new, but not totally new, but newish agents. So novel agents that are currently FDA approved, and covering some key points here. So the mechanisms of action, so we understand how they fit in with our other antiretroviral therapies, the evidence base for their use, which I think comes into the decision-making of when you would decide to use a novel agent versus using an approved agent. And then also where there is any emerging real-world experience. So which agents are we going to cover today? So ipilimumab, which I'm going to blank on the trade names. I think this is Trogarzo, great, and fostemsavir, which is Rukobia, and lenacapavir, which has a very cute name of Sunleva. And we were originally going to also talk about cabalpivirine in this context. We got a really beautiful overview of a lot of that from Kristen Kilcrease a couple of months ago now, but that was a little bit more dense, to be honest, because there's just more data. And so we're going to save that one for a separate conversation. And I think probably also elicit from some of the providers who've had their patients on it, their experiences and questions. So let's start off first with ipilimumab. So what is ipilimumab? So this is a graphic that I made with BioRender, where the HIV virion is coming in contact with CD4 and potentially will interact with either CCR5 or CXCR4 to allow the viral particle to fuse with the membrane and go through. So where does ipilimumab act? So it actually binds to domain 2 of the CD4 molecule itself. So it's binding to the host CD4 molecule. And when the CD4 then contacts GP120, which is this like trimer that you see here on the surface of the HIV, the bound antibody here prevents a change in protein conformation that allows the virus to come in close proximity with the membrane and eventually to get in. So it's an IgG4 antibody. So what that means is partially, and where the back end, so the end that sticks off, has been modified to prevent our own immune systems from recognizing antibody and removing the cell, because the way antibodies often work is they bind to something and then our other immune cells recognize that sort of stem end and remove whatever is bound. So it's modified to prevent host recognition of the antibody and is supposed to just sort of block this transition between bound GP120 and CD4 into the close approximation of the virus to let the virus actually enter the cell. So what are the FDA indications for use of this? So limited to heavily treatment-experienced adults with multi-drug resistant HIV, and this was defined in the trials as resistance to antiretroviral drugs from 3 different classes, who are experiencing treatment failure on their current regimens. And the dosing is a single loading dose intravenous infusion of 2 grams or 2,000 milligrams over 30 minutes, followed by maintenance doses of 800 milligrams over 15 minutes every 2 weeks. So it obligates an intravenous dosing protocol. So what is the evidence base to support use? So there's a phase 3 study, and N equals 40 adults, of whom 31 actually completed the study. The age range for those who were included, it was above 18, was 23 to 65. Their weight ranged from as low as 50 kilograms to up to 130. They had resistance to ART from 3 classes. And viral load, they defined here to inclusion criteria, was greater than 1,000 copies per mil, despite being on antiretroviral therapy for 6 months. So the mean HIV viral load was 4.5 logs, so in the 10,000 to 90,000 range. And the mean CD4 count was 150 cells per millimeter cubed. So advanced disease, most of them had higher viral loads. It wasn't like people who were hanging out with viral loads in 1,000 copies with CD4 of 800. So then a few other points. You had to be able to craft an optimized background regimen, or OBR, or OB optimized background treatment, OBT, and that had to include at least 1 active agent. And to achieve this, 17 of the 31 patients in this trial actually used fostemsavir, one of the other novel agents we'll talk about next, as part of their optimized background regimen. So just keep that in the back of your mind. And so what was the trial design? So there was a screening period that started at -6 weeks, then there was day 0, and that's a control period. And they're going to compare what happens to your viral load over a week to what happens when you add ibalizumab. So the control period, day 0 to 7, let's say, if you were to measure someone's viral load every day, you might see a certain amount of variation. We don't want to interpret that as a drug effect. So day 0 to 7 is your control period. And then from day 7 to 14, you continue on whatever you were on before that was failing, and you only add ibalizumab. So then you have the functional monotherapy period for another week, and then you add the background regimen at day 14, and then continue through a maintenance phase where you're getting your regular ibalizumab. So the idea of that week is that we get to see the effect of only the drug on and not the rest of the regimen, and then the rest of the study to say like, okay, but let's give it our best try. Like, let's not just add to something that wasn't working. So that's the overall study design. Any questions or comments so far? Okay, so then the primary endpoint of this study is actually the day 7 decrease in viral load. So what happens after that functional monotherapy period was sort of their primary pre-specified endpoint. And they saw 83% of participants had more than a half log decrease from baseline at that point. And then when they looked later in the maintenance phase, 43% of the participants achieved an HIV viral load of less than 50 copies, with a mean decrease of 1.6 log per copies per mil from baseline. And then in the week 48 open label extension, or OLE, 24 of the 40 were still taking ibalizumab plus their optimized and background regimen. And 16 of 27, 59%, had an HIV viral load of less than 50 copies. So overall, these results are nothing like, starting Biktarvy in a treatment-naive person. We're not achieving viral suppression anywhere near those rates, but these were sick people with a very long history of HIV in many cases and lots of resistance. And this did achieve in 43% of participants an HIV viral load of less than 50 copies. And so what happened in virologic or failure or rebound? So in 9 out of 10 of the individuals with virologic failure or rebound, and virologic failure means that they didn't really go down, they never achieved suppression, whereas rebound means you got to suppress and then you came back up. They had decreased ibalizumab susceptibility at the time of failure compared to baseline, suggesting that there was emergence of resistance to the agents that we are studying, in this case, ibalizumab. And to be just to clarify that, so although it binds to the host, there's changes in GP120 that allow the conformational change to occur. So it's actually mutations in the virus that are causing escape from the binding, so the antibody can still bind to the host CD4. We wouldn't expect that to change over time. But what happens is something in the GP120 molecule changes, which allows it to then still make the change it needs to get close to the membrane. So what were the adverse effects? Most common or more common diarrhea, about 20%, rash, nausea, headache, dizziness, depression. Common but severe included iris and some hypersensitivity reactions. So iris is going to come up as a theme with these novel agents. You know, I always struggle with that. You know, it's in part achieving a state of immune reconstitution. And, you know, in at least some of the studies with iris, continue the treatment. Whereas I would think maybe we should just add corticosteroids depending on what the triggering event of the iris was. But when you're, you know, well, that's not really what happens. And so the resistance is lost in these N-link glycosylations on the HIV V5, the glycoprotein GP1. Again, all little red knobby thing, some sites on it that get sugars added to it. There's a mutation in one of those sugars, and that then allows it to make that change. So all of that V5 loop and whatever is just, there's something that happens in the GP120 that allows it to then still approximate closely with the membrane despite the antibody being bound. And then there's no evidence of cross-resistance to other antiretroviral therapy because it's pretty novel site on the virus that's impacted, and it's active against R5, X4, and dual tropic viruses because where it binds and how it prevents that change is sort of before it interacts with the CCR5 or CXCR4 co-receptor. And then on this last point, I'm going to sort of punt over to Ethel to talk a little bit about the sort of unknowns, which would include risks of reproductive toxicity.
Yeah, so Eileen, I think one of the things with some of these new agents, given that they achieved, that actually for this agent, both breakthrough therapy designation and orphan drug regulatory approval pathway, meaning there's few enough people in this country who have 3-class drug resistance and are heavily treatment experienced that they constitute that this is fairly rare and that an expedited pathway is warranted. And then sometimes that means that the human safety database for these agents is smaller when they enter the market. What was seen in preclinical studies for ibalizumab in macaque studies was immunosuppression, both T cell and B cell lymphocytopenia in macaque infants that were born to mothers exposed to ibalizumab in pregnancy. They got severe viral and bacterial infections, and one of them died in this study because of acquired infections related to the lymphopenia. So certainly it's the case that other drugs with similar monkey signals have raised alarm when given to women of reproductive age. One example is efavirenz, where the monkey study signal did not bear out in later human data. But it's something to consider when we're giving this agent to women of reproductive potential, and something certainly to be discussed with them, that there is this unknown and that should be taken into consideration when these drugs are considered.
No, Ethel, those are great points. And I think, it highlights the limitations of the ways in which we can assess reproductive toxicity in preclinical studies. And in particular, in this case, because, I don't know actually for this, did they macaquize the antibody? Because as it stands now, it's a humanized IgG4. So you would expect that there would be a different sort of macaque interaction with that antibody tail, which can lead to either over or underestimation of potential adverse effects. And I think also one area where this could probably be sorted out a little bit is looking to see at transplacental transfer of IgG4 modified antibodies in humans in general. But again, it seems like we just really don't know quite yet.
Yeah, great points. I don't know whether they macaquized this humanized antibody, and I do think that can lead to differential safety signals. But yeah, great points.
Okay, and then I thought we'd just take a moment here so that this was sort of the overview. And again, the point of this is just provide a thumbnail sketch of these new agents, because we've started bringing them up in conferences, potential additions, but not everybody has had the chance to go and sit in a CME course or listen to the FDA approval hearings for all of these agents. So I know that Joyce has a patient on ibalizumab. I don't know if anybody else does, and I think I saw Joyce here earlier, but I don't know if anybody had any comments on like sort of real world experience with use of this agent, because I actually don't have anybody on it.
Yeah, hi, I'm on the call, and I presented this patient a few weeks ago here in conference, and he really is not. He has definitely resistance in all classes. His current regimen, he has his cumulative resistance. He's resistant to all of the oral medications that he's on, and he's doing well. He on his before ibalizumab was approved, he achieved an undetectable viral load just on his medications that theoretically should not have worked. So he was suppressed ahead of time. Kristen really helped me get the approval for him to start ibalizumab. And since he's been on it, his viral load at times is completely undetectable, and then at times it'll be at the highest 50. And in his case, he's the one where I did a genotype ahead of time. It did not show the old resistance that he had, and then I did a GenoSure. It also did not show much of that old resistance, but then now he is the most recent GenoSure I showed some of those old resistance mutations, but not ones that impact the oral agents he's on. So right now, he is on boosted darunavir, boosted darunavir. He's on bictegravir, TAF-FTC, and doravirine.
And Joyce, has he had any intolerance to the infusions or like any other adverse effects from the actual agent, or anything else you've thought that was attributable to ibalizumab, or has it been generally well tolerated?
It's been very well tolerated.
Okay. And I think
he's done really well.
And you had mentioned that sort of that anchoring around the every 2-week visit seemed actually useful for him. So I think in terms of thinking about which of these agents are best for patients who have limited options, like someone who embraces that medicalization and the sort of touch point is probably a good one. Great. Anybody else who has any experience with ibalizumab or any comments on it?
The only other comment I'll make, Eileen, for my patient is, this idea of fostemsavir, like whether or not we should add it. It is a twice-day regimen. I, don't know how successful he would be with it. So that's, something that.
Given the number of people in the trial who were
exactly
also, so because if he truly had no other fully active agents, then
exactly
in the context of the trial for his optimized background therapy, he would have been recommended to be on fostemsavir.
Yes.
But your experience thus far has been that, I think although he probably would have been excluded from the trial because he suppressed before entry. So from that perspective, you could still defend what you're doing in terms of like he was able to suppress even before. So anyway, that's a really good question, and one that we should keep thinking about, because I think, again, the experience of this, there was 31 people in this trial, right? So now we have talked about 32, but with Joyce's patient. So not a whole lot of people. Oh, and Dave Griffith is saying he has a patient, did very well, though there was treatment fatigue with the every 2-week visits. Yeah. So again, like thinking about who this will work for and who it won't. Because I think, as Joyce is sort of intimating there's some people for whom every 2-week visit is better than a twice-a-day pill, and some people where it's not. Oh, and Mickey is saying on some data on Rukobia that it might be able to given once. So we will use that as a transition point to talk about fostemsavir or Rukobia. So what is this and how does this work? So again, we're here at this like interaction point, and fostemsavir, it binds to GP120, the little red knobby things adjacent to the CD4 binding site, and just preventing that conformational change that is required for HIV attachment to the CD4 molecule. So that is sort of not acting at the same place, right? Ibalizumab's on the outside of the CD4, not interfering with this. So in theory, they can be used together. They were used together in the ibalizumab trial in a substantial proportion of the patients, and as Joyce is mentioning, could be considered for dual therapy. So what is the FDA indication for Rukobia, and what does it look like? So I couldn't get a good size comparison, but it looks moderate sized and not small, not petite. And the FDA labeling indication is for in combination with other ART and heavily treatment experienced adults with multi-drug resistant HIV infection failing their current antiretroviral regimen due to resistance, intolerance, or safety considerations. And the dosing is 600 milligrams. Tablets taken twice daily. I'm not aware of the data about once daily dosing, so maybe we can get to that after we go through just the original assessments. So what's the evidence base? It's primarily from the BRIGHT trial. So this was adults failing current ART. Here the definition was more than 400 copies per mil. Last one, it was more than 1,000 copies per mil. No available ART due to exhaustion of 4 of the 6 available ART classes. They define those 6 classes as NRTIs, NNRTIs, protease inhibitors, integrase inhibitors, CCR5 antagonists, and fusion inhibitors. And you could have exhausted the fusion inhibitor class by not wanting to do T20 injections twice a day. So that just in thinking about what the exhaustion meant there. If there was one available additional agent, so that like one fully active agent for your optimized background regimen, then you went into a randomized cohort. If there was nothing else available, you went into a non-randomized cohort. And so then what happens to you once you're assigned your cohort? So in the randomized cohort, they were randomized 3-to-1 to either receive blinded fostemsavir 600 milligrams twice daily plus your failing regimen for a week, and then roll over into open label fostemsavir twice a day plus your optimized regimen. So you optimize and continue. And then if the 3-to-1, the one group was a blinded placebo twice a day plus your failing regimen for a week, and then roll over into open label fostemsavir. So in the last trial for ibalizumab, they used that like 1 week before you get the ibalizumab as your own personal control for your viral load. And here they're using an actual placebo control group who doesn't get anything as the control to look at the sort of single drug effect of adding fostemsavir. So 2 sort of different ways of trying to assess what the drug is doing on its own. One where you're using people as their own control, and one where you're using a group that doesn't get anything until everybody gets fully active. And then the optimization point happens here. And so again, this first period just to look and see what the drug does on its own, and then the second period to look and see how it adds to a more robust regimen. So, and sorry, that's day 8 is the primary endpoint, and then day 9. So 7 days of whatever that was, and day 8 was the primary endpoint. And again, primary endpoint for the study is the difference in change in baseline viral load, whether you got fostemsavir or you got placebo. And then in your non-randomized cohort, so these are people with no fully active antiretroviral drug regimen, they just get open label fostemsavir twice a day, plus their optimized background treatment, and they're just looking at week 24, week 48, what happens to your viral suppression. So 272 people, so a lot more than the iberalizumab trial, underwent randomization. They were on 6 continents, 31 countries. 215 completed the trial. 99 were included in the non-randomized cohort, so they didn't have any known active agents, of whom 67 are in the ongoing completed trial, or not ongoing at this point, but in the completed trial. So the median age of participants was 48, 67% were white, 74% were men, 85% had a prior AIDS diagnosis. The median viral load was 4.7 logs, so again, in that sort of 10,000 to 90,000 range. 68% were above 1,000 copies. And I think that's an important number. If you're like hanging out at 400 to 500, you're a little bit different than you're for 1,000 or above in terms of your risk for resistance and progression. The optimized background regimen had 1 additional fully active agent in 52% of the people. So that means that some of them had 2 agents in their optimized background regimen that appeared to be fully active, which, you know, sort of, then you're sort of like, well, why couldn't, anyway, 2 agents in the fully optimized background regimen in the randomized cohort, and 42% had 2 active agents. So the primary endpoint, day 8 change from baseline HIV viral load. So the mean change was just shy of 0.8 log copies per mil versus just a 0.2 log 10 copies per mil in the placebo. So that would be the variance we'd expect with randomness, whereas we're actually seeing a decline in those who received fostemsavir in that first week. And you looked only in those with the baseline viral load greater than 1,000. Again, we see a nice robust 0.86 log 10 copies per mil drop in the fostemsavir group versus 0.2 log 10 copies in the placebo group. And so then what does this look like over time? Great, whatever you can do at a week, what can you do over time? So here the dotted line is HIV less than 200 copies, which was 84% of patients at week 48, of whom there were 233 patients remaining, and less than 40 was 62% of patients that achieved and maintained that at week 48. So again, that's like a month shy of a year. And in the non-randomized cohort, where they didn't have anything in the optimized background regimen that was fully active, they got close to 54% at less than 200 and about 48% at less than 40 copies per mil at their week 48 endpoint. And then looking at their CD4 T cell response, so this is a median mean change from baseline. So here we're at about 49 cells at the start in the randomized cohort and 31 cells per millimeter cubed in the non-randomized cohort, getting a doubling in the non-randomized cohort and up to 139 in the plus 139 in the randomized cohort. So a good immunologic response, reasonable virologic suppression response. And so how was the tolerability? So adverse event data is from a total of 620 people who've ever received a dose. Many of those would be in dose ranging studies or who got a single dose at some point. But the primary safety information comes from this BRIGHT trial, which included 370 people who got any doses. The week 96 discontinuation rate due to adverse events was just 7%, so overall pretty low. And the adverse reactions between grades 1 and 4 that were reported in more than, or at least 2 or more than % of patients was nausea leading the way at 10%, diarrhea, headache, abdominal pain, and a couple of other things. And among the serious ones, again, we saw the risk of immune reconstitution syndrome, which again is kind of like a double-edged sword in terms of like you want your immune system reconstituted. The drug-drug interaction profile, it does interact with one of the main Hep C treatment regimens. So keep that in the back of your head. Also interacts with ethinyl estradiol preparations and enzalutamide, which is an additional androgen deprivation agent. So I mentioned those just because I think we sometimes think of hormones as being outside of the realm of drug-drug interactions, but some of these synthetic hormones and hormone blockade pathways actually can be impacted by other drugs. Has interactions with statins, and then like the usual suspects like rifampin, carbamazepine, phenytoin. So pregnancy and lactation data are inadequate, meaning there isn't human data. There are some animal studies which have, looking at, I think there were adverse effects observed at about 1,000 times the maximum human dosage exposure, but again, with pretty unclear implications for their use in pregnant women. It was detected in breast milk, and it does appear to cross the placenta. There are no hepatic or renal adjustments. So I think the last thing we'll just cover here is resistance. So in patients who were treated, of participants who had virologic failure in the randomized cohort, so they had one other thing in their optimized background regimen, there were treatment emergent GP120 genotypic substitutions at 4 key sites. So we're not calling them resistance mutations because they haven't been defined in that classical way of saying that if you have these, you will have a reduced response. But they are things that if you expose the virus repeatedly to fostemsavir in vitro, you will develop these substitutions over time. And these were observed at 4 key sites in about half of patients who had virologic failure. The median EC50 fold change with these mutations was over 1,000, so substantial loss in activity. And if you didn't have changes in these sites but did have virologic failure, the median fold change was much lower, which might suggest that there might be adherence issues or other things that were driving the lack of efficacy in that group. 48% of the participants with virologic failure had emergent resistance to at least one agent in the optimized background regimen. I think this is important to keep in mind. When you fail, do you fail with resistance only to this or to other new resistance to your other agents? And so close to half of the people who failed did get new resistance to other agents when they failed their fostemsavir. Again, heavily treatment experienced population with very limited options, so it might be hard to not get more problems. And then in the non-randomized cohort, so here, again, nothing active in the background, 73% had emergent substitutions. So again, when you don't have anything else, of those who fail, many of them will have emergence of these substitutions. And then what about cross-resistance? So it turns out that there is some potential cross-resistance to both ibalizumab and CCR5 antagonists because of the location in GP120 where these 4 changes are occurring. And that may mean that if you have resistance to fostemsavir, you may have lower resistance to ibalizumab or CCR5. Now, keep in mind that these regions are not covered in our genotypic testing. Like you can't look at genotypes and say, oh, well, we predict that this will happen. That covers the reverse transcriptase, the protease, and the integrase, not GP120 substitutions. And they're not yet robust enough to say like, okay, this means it definitely work. So this will be an area that we continue to watch, but also one to keep in mind if you are considering using these agents. So then I'll just stop there. And Ethel, do you have any comments and if people have start getting ready to talk about your patients who have used this agent, because again, I don't have anybody who's on this.
Yeah, Eileen, great summary. I guess the only thing I would add is a little bit of color commentary on the drug-drug interactions. So fostemsavir, as I think Eileen mentioned, is a prodrug. It has like a methyl group and a phosphate group, and it's a prodrug of the active metabolite temsavir. And when you take it orally, it's very rapidly converted by alkaline phosphatase in the intestinal epithelial border to its active metabolite. So that happens without too much implications of kind of variation in metabolizing ability between individuals. But then the temsavir itself undergoes metabolism via hydrolysis, that's just plasma or serum esterases or intracellular esterases, and then by oxidation via CYP3A4. So that active metabolite is the substrate for CYP3A4. And this is why it's not recommended to give it with strong 3A4 inducers, because the plasma concentration of that temsavir is significantly lowered. So you don't have enough active drug around, which would set up conditions favorable to resistance. And there have been studies done in terms of its co-administration with cobicistat and ritonavir. And I will say that those agents, when co-administered, increase the C-tau, so the trough, by 136%. So they definitely do make more of the drug hang around. It's felt that this is acceptable because it still stays within your therapeutic window, i.e. you're not pushing up to the margins of toxicity. What is the toxicity I would be most worried about? QTc prolongation, especially in combination with other drugs that can do that. So when fostemsavir is dosed at 4 times the package recommended dose, so 2,000 milligrams instead of 500 milligrams, QTc prolongation that was clinically significant was seen. And that would be the thing that would make me a little bit wary about dosing it once a day, as was mentioned in the chat. So giving both tablets once a day rather than giving the tablets twice a day. And sorry, I got the dosing amount was 600 milligrams per dose, and then the 4 times was 2,400. So that would be, I guess, one of the considerations is if I were to be dosing it that way, which is not the recommended dosing, I would definitely be monitoring QTc. So that was just one thing to add, and then what it does in terms of its implications as a perpetrator against other drugs. This is with the ethinyl estradiol, sort of either female hormones for our trans patients or for people on estrogen-based contraceptives, is it actually hoists the levels because temsavir itself is an inhibitor of metabolism of certain hormones via effects on the OATP transporter and the BRCP and things that are somewhat not worth memorizing. But basically what it means is that hoists your estrogen levels up to a point where you might be at more risk for thrombotic events. And so just thinking about the holistic picture of what am I doing to other agents that people might be on by giving this drug, I think is important.
And then I saw there was a question about CD4 recovery. I mean, I think in both the ibalizumab and the fostemsavir study, there's good evidence that with the treatment, there is improvement in CD4 counts. But Mickey, I'm not sure if you had another question.
I'll unmute. I recently had attended a talk. They were discussing that people who were initially on treatment suppressed, and they were switched to Rukobia and they had lower CD4 counts, so let's say 200, 300, it went higher than they came to 5 and over after fostemsavir was added.
Okay, so a switch there. So not any of the data that we covered here. So I think that is that is one of the holy grails of ongoing patients with viral suppression with failed CD4 counts. So if it were true that switching agents could lead to improvement in CD4 counts, that would be interesting. That's not something that we can really comment on based on the initial registrational approval level data, but maybe some of the updates from the data presented at recent meetings will give us some more insight into that. So it's a good point as we think, although it's like a kind of a slightly off-label use, not slightly, would be an off-label use of the agent as it stands now, because currently it's really only for people who can't achieve viral suppression. But a good point. So then I'll just switch, because I want to be mindful of the fact that Sheila is here, to our last new agent, which would be lenacapavir. And I think we'll see how far we can get. But Ethel, I think maybe if we need to stop, we can do just the salvage as opposed to the treatment initiation, and then we'll cover treatment initiation and cabrolpivirine on a future session.
Okay, so Capella and not calibrate?
Yeah, I think so.
Okay, so next slide, please. Oh, sorry, I can just talk about mechanism for a quick second, and I'm aware that we have 5 minutes before Sheila needs the floor. So this agent is an inhibitor of the HIV capsid at various different stages of the life cycle. So at the point of nuclear transport, at the point of assembly of virions and release, and then capsid assembly thereafter. And again, like the other agents we've been discussing, has the FDA indication for heavily treatment experienced patients with 3-class drug resistance, failing their current ART due to resistance or intolerance, or some safety consideration with other agents that they're on. This is the dosing approach. So the first option is you give 927 milligrams by subcutaneous injection, usually to the skin of the abdomen, or subcutaneously to the skin of the abdomen. So it's 2 different 1.5 ml injections, 600 milligrams orally, which is 2 300 milligram tablets, given as well to get your levels up to therapeutic quicker. So this is part of a loading approach to give them simultaneously. And then day 2, 600 milligrams orally to complete that load. And then the other option is to do loads of 600 milligrams on day 1 and 2, and an additional 300 milligrams on day 8, again, oral long-acting agent. And then day 15, initiate your subcutaneous injections. And then the maintenance, once you've gone through this loading period, the maintenance is by subcutaneous injection, 2 1.5 ml injections every 6 months from the date of the last injection. These are some of the instructions for how to access the vial and draw it up and inject.
And Ethel, Luis just asked does this have to be provider administered or can it be patient administered? I mean, it's every 6 months, which gives you a lot more flexibility in terms of.
I've not heard of this being administered by patients yet, but I think it's very fertile territory for investigation, just to make sure, you don't want to maladministration to mean that they don't have good levels for the next 6 months. So for now, I've heard of providers doing this, but people are talking about that a lot, even for Cabenuva, whether new data on thigh injection and gluteal injection being equivalent PK wise means that auto injection at home is going to be the wave of the future. But I think for now it's provider administrated. So Capella was a study which basically took a trial design with patients with multi-drug resistant HIV, assigned to one of 2 cohorts according to the change in their viral load between the screening and the cohort selection visits. So in cohort 1, they were randomly assigned to receive either oral lenacapavir or placebo, plus their already failing drug therapy for the first 14 days, and then subsequently received subcutaneous lenacapavir or oral lenacapavir, along with an optimized background therapy. And then in cohort 2, all the patients received oral lenacapavir, followed by subcutaneous lenacapavir once every 6 months, and started optimized background therapy at day 1. And they, as a primary endpoint, they looked at the percentage of patients in cohort 1 who had a decrease in viral load from baseline of at least half a log. So that's what they were shooting for. And they well overshot that, as you'll see on the next slide. So by day 15, they wanted at least half a log drop. And you can see that there's probably a 2 log drop, a 2.1 log drop in viral load at day 15 among those on lenacapavir as compared to placebo. And the panel B basically shows the randomization and treatment schedules in the 2 cohorts as of the data cutoff at week 26. So in cohort 2, among 36 patients, 3 did not meet the criteria for reduced viremia during the cohort selection visit, whereas 33 were enrolled in the trial after closure of cohort 1. It's a fairly diverse population in this study. I believe 25% were women, so that could be higher. 38% were Black, 21% were Latinx. And the median CD4 count at baseline was 150 cells per cubic millimeter. And they actually did include people who are not always embraced in trials of new agents. So that's adolescents over 12 years of age, and people with a relatively high body mass index. And just to go to the next, so as to speak a little bit about CD4 count recovery, which has already been raised. So in cohort 2, CD4 count increased by 104 cells on average with the error bars displayed. And then in cohort 1, it increased by an average of 75. So clearly some immune recovery was observed on this agent. Next slide. These are the adverse events, and I will just point out that injection site reactions at the site of the subcutaneous administration were highly frequent. So 65% of individuals had some injection site reaction. Mostly it was pain, and then in some case, kind of swelling, and then some amount reported this kind of hard nodule formation that was a little bit more long lasting. And then in terms of other adverse events, nausea again led the way. In terms of the resistance that was observed with Capella, so 8 of 72 participants did develop resistance-associated mutations while on lenacapavir. Many of them were seen to have poor adherence to the optimized background regimen. And often these mutations, though present, did not prevent their viral resuppression, despite a laboratory-defined quite significant fold change in susceptibility to lenacapavir. So I think those would be my takeaways, is that though these mutations were seen, often people were able to resuppress on len despite them. And then in terms of drug-drug interactions, DOACs, anticonvulsants, rifampicin, some various ART, and then corticosteroids are all implicated with drug-drug interactions. So it's the sort of agent where you definitely want to put this into your liver pool or Micromedics drug-drug interactions database before considering it. Next slide. I just think that it's important to consider what are the partners. So if we're giving this because it's a long-acting option for people who really struggle with daily oral ART, what are our long-acting partners? And this has not been studied in combination with Cabenuva, and I wish that it would be. And I don't think that that's coming down the pike relatively soon, but it will, in a rare cross-pharma company collaboration, be studied with oral forms of lenacapavir. So potentially it will have an oral long-acting partner. But could you partner it with other oral ART? Will you need to? Is that a good idea? These are all questions that really need to be asked and answered.
And I'll just mention here that Ethel has included a whole bunch of slides about the Calibrate trial, which looked at some of these partnering in treatment naive individuals, but we'll have to save that. So everyone, please stay tuned. Ethel will come back. She will tell us about—
You don't have to save, keep going. We can't do our things in 10 minutes. So go ahead, keep going.
I'm sorry, Sheila. My time management skills are just never going to quite get there.
It was my blabbing. I'm sorry, Sheila. Sorry about that.
It's okay. Thanks.
So then let's try to do the Calibrate trial. Why don't you go through that, and then we'll do the capivaparin at a separate one.
Yeah, so this was a study of lenacapavir in treatment naive individuals, 182 individuals who had not previously been on ART therapy. They had to have a viral load of at least 200 copies per ml and a CD4 count of at least 200 cells per microliter. And they were assigned randomized to 4 different groups. So either lenacapavir subcutaneously every 26 weeks, as compared in combination with oral emtricitabine and TAF daily, so kind of Descovy plus lenacapavir, and then switched to just daily oral TAF, so a 2-drug regimen continuing, or lenacapavir every 26 weeks with the Descovy that was then switched to daily oral bictegravir, which is hard to find apart from its partners, but this particular company would be the one to find it. And then they compared it to group 3, which is oral lenacapavir 50 milligrams daily, and oral emtricitabine TAF. And then just the comparison group was BIC, TAF, FTC. And they had overall excellent results. Group 4 had 92% suppression at the primary endpoint, which I believe was 26 weeks. And then the other groups had similar excellent suppression, including group 1, which is the lenacapavir plus TAF FTC of 90% suppression. So you can see them all plotted there, not looking meaningfully different, with not having any viral load data being the most common reason for being counted among the not suppressing. And it's just important to note that there were emergent resistance mutations to lenacapavir. They occurred in 2 out of the 157 participants who got lenacapavir. They seem to be associated with incomplete adherence to oral daily ART. So in the Len subQ plus BIC arm, for example, the mutations Q67H and K70R emerged at week 10, and they followed, and those are lenacapavir mutations, they followed a mutation that we see when people don't necessarily take integrase drugs as they are supposed to, which emerged at week 4, which is the M184MI. And so they're basically the gloss on this was that a lack of adherence to the oral part of the regimen, leading to functional lenacapavir monotherapy, may have contributed to the development of resistance rather than an issue with the drug itself having a low barrier to resistance. Yeah, so that another participant in group 3, which was oral Len plus TAF, had poor adherence to both, as documented by plasma drug concentrations, and got the Q67H resistance associated mutation. Next slide.
Yeah, I don't think there was much difference in the AEs.
Yep, AEs seem fairly similar across groups. I mean, obviously the ones that were on subcutaneous lenacapavir were more likely to have an injection site reaction. And then when to consider it and how to dose it, we've already gone over the dosing. And again, really considering it in heavily treatment experienced patients, and potentially in combination with other ART in the future among the ART naive.
Yeah, because I mean, I think that the tempting thing from that initial look in the Calibrate study at initiation of therapies would be that this could potentially be an option for, very sparse, like unlike cabrolpivirine, they did start with people with detectable viral loads. So it could be an initiation, and could you initiate it in someone who just has adherence problems and doesn't have a ton of resistance? But then again, I think to your point that you had already started to discuss, like, what are the partners and what are the best options? Because if we can give Biktarvy as 1 pill a day, like if you have to take the Descovy, like in order for the lenacapavir to work, does it really help to do lenacapavir plus daily Descovy? I'd be interested to know what you think, or if others have thoughts about that, because that seems to sort of defeat the purpose of unless you get another truly long-acting agent.
Yeah, I think it does subvert the purpose of freeing someone from oral drugs, because that you have not done that. You're still requiring them to take oral drugs, and indeed, this trial shows that when they do that imperfectly, they develop resistance to the long-acting agent. So I think the partners are lacking, and I think need to be developed.
So I'll just stop sharing. Does anybody have anyone on lenacapavir or have experience with using it? Unwilling to admit it. Zero from Matthew. Yeah, I mean, I also don't have any. I mean, I think, to be honest, I have been less of an enthusiastic uptaker of cabrolpivirine because of the, that uses 2 of our classes that we use for oral agents, and the idea that, having a long-acting agent with a novel mechanism of action like lenacapavir seems very attractive in terms of then if you go off of it, fail it, whatever, develop resistance, we would still have our other sort of mainstay oral classes available. I was very hopeful for the potential pairing with the islatravir, and now with that seeming much, much less likely, it seems like we will maybe not have a perfect answer to that problem. but I just think it's interesting that we have these 3 agents that are all FDA approved and while not necessarily easily accessible, are really have a very niche use. And I searched yesterday and today for any updated information about ibalizumab, for example, and there's no published reports of updated information about its use or characteristics. So we still have a very, very small reported experience with a lot of these drugs.
Yeah, and I mean, it's one thing for people to decide as a society that we only need, 200 people and a safety database to roll out an agent that is for which there's a desperate need. But then the pharmacovigilance becomes much more important. And we looked for the pharmacovigilance and it's hard to find. We don't see a ton of people reporting on real world experience with this. Although just one thing to add in response to one of Eileen's points is that one of the things that we heard at CROI about the Ward 86 project is among individuals who really had an incredibly high viral load initially, they actually did use Cabenuva with lenacapavir. So that's one of the first described uses of that combination. And it's important to look for future uses, but there, as of now, there's really not data. We don't know.
Yeah, I think that'd be really interesting to ask Monica about. Go ahead, Matthew.
It was a question for Joyce, really. Does your patient have to come in every 2 weeks, or is it something that can be delivered by an infusion at home?
He actually comes to Park Infusion every 2 weeks. I mean, I think, and Matthew can speak more to this, just like involving home care with administration. I mean, I think, obviously logistically, it is possible for people to, go to people's homes and offer infusion, but whether or not that will be covered, whether or not home care would actually do that, I think is another question. But he comes into the clinic every 2 weeks, or he comes to Park every 2 weeks.
And I also see there's just a note in the chat that Mickey has a colleague in Pennsylvania who's using fostemsavir and lenacapavir in a highly treatment experienced patient, and it's working well for now. And then also mentions this idea of using with cabrolpivirine. And I mean, I think it'd be interesting to hear about again, in the absence of trial data, it's always hard to use those combinations, in particular with the long acting, where I feel like our understanding of the pharmacokinetics is a little bit less solid than for a lot of the oral agents, but emerging data for sure. Well, if nobody else has any comments, thank you so much, Ethel, for your presence on these meetings. It's incredibly helpful, and for keeping us so up to date on these new agents. We will also try to find some time to talk about the cabrolpivirine emerging data on the real world experience of that use and predictors of failure. Thanks everybody for being here and for participating. And sorry to Sheila.
Thanks, Eileen. Thanks everyone for listening.